Um, you can just present the sort of history of the hypertension. That's fine. We're just going to do a discussion on that only. So that's okay. You don't have to describe the presenting complaint.
Okay.
Okay. Right. Just the introduction and then just describe the past medical history and anything relevant. Yeah.
Okay, sir. Shall I start, sir?
Yeah, you can start. Yeah.
Mrs. Bhagya, 26-year-old university student from Kaluthara, who is currently reside at Colombo. She is a diagnosed patient with hypertension for 1 year duration. She is diagnosed to have hypertension at the age of 25 years. She was well until 2017 and started to develop episodic headache, mostly unilateral, for 2 year duration, for which she has been treated as migraine and was on prophylactic treatment with flunarizine. In July 2019, she developed severe frontal headache, which was associated with dizziness and vomiting for 1 day duration. When she consulted a GP, her blood pressure was detected to be high with 160 by 110 millimeter mercury. Then she got admitted to hospital. At that time, she did not have visual disturbance, palpitation, or sweating. She did not have history of childhood renal disease with hematuria, generalized body swelling, frothy urine, or reduced urine output. There was no associated muscle weakness with difficulty in climbing stairs, getting up from seated position, and she also not noticed any sudden onset of weight gain. There was no excessive sweating, tremor, increased appetite with loss of weight. She was also not informed about blood pressure differences in both arms or not had any leg pain on walking particular distance. She has no history of rashes, photosensitivity, increased hair loss, oral ulcers, or joint involvement. She also had no complication associated with hypertension, such as ischemic heart disease, chest pain, shortness of breath, difficulty in breathing when lie down, or waking up during sleep due to the breathing difficulty at night or ankle swelling.
Okay.
And there was no history of stroke. There is no emergency hospital admission due to elevated blood pressure. She was evaluated for the cause of hypertension. Um, During the initial admission, she underwent blood urine investigations, 2D echocardiogram, ultrasound abdomen, renal Doppler scans. Uh, Other than the low potassium level, all the tests were told to be negative, and she underwent special investigations with several hospital admissions, which included 24-hour urine collection test, 24-hour blood pressure monitoring, and repeated potassium levels and special blood investigations. And all
Okay.
those investigations were told to be normal.
Mm-hmm.
She was started on antihypertensive drugs. Now her blood pressure is under control with 3 antihypertensive drugs. She has good compliance to medication and properly followed up at the private sector. In her drug history, she was initially started on um, prozazine, then changed to the captopril following side effects of the drug with increased dizziness, sleepiness, which disturbed her studies and activity of daily living.
I'm sorry, sir, what was the
Other
first drug? Prasusin, is it?
processing, sir.
Okay, right. Hari. Yeah, you can continue. Sorry about that.
Over the time, captopril was also stopped, and she doesn't know the reason.
Uh-huh.
Currently, she is on indapamide 1.5 milligram mane,
Mm-hmm.
diltiazem 5 milligram mane, captopril
Okay.
50 milligram noctine, and
Right.
she is
Okay.
not on any oral contraceptive pills.
Okay. Okay.
Her past surgical history is not significant. She has no known allergy to food, drug, or plaster. In
Mm-hmm.
family history, her father also a hypertensive patient since 40 years of age and on antihypertensive treatment. Her
Okay.
mother has diabetes mellitus, hypertension developed after the 50 years of age, and she also has chronic kidney disease. She is on treatment.
Okay.
Her elder sister is on treatment for hyperthyroidism, no family history of polycystic kidney disease, other renal diseases, ischemic heart disease, or stroke.
Yeah.
In social history, she is married, currently studying in university, and stay at the hostel. She is a non-smoker, non-alcoholic, not used any illicit drugs, financially stable and supported by the family. No social issues. Her mother is taken care by the elder sister who is married. She is not. She does not have a major impact on activity of daily living due to the illness. She has missed her studies due to the repeated hospital admission for the investigations. Currently living in the hostel. Uh, Her present complaint was fever, and there are several students were affected due to dengue fever at the time.
Okay. Right.
Uh,
Okay. Shama, with relevance to hypertension, did you find or young hypertension? Did you find anything relevant in the examination?
no, sir, all the system examination was normal.
Okay. Right. Fine. Could you just summarize what you just told us?
Uh, Mrs. Bhagya, 26-year-old female from Kalutara, who is
Mm-hmm.
a university student present with fever for 1 day duration and also has a background history of hypertension, diagnosed at the age of 25 years, evaluated for the secondary causes of hypertension, and now blood pressure is under control with antihypertensive treatment with good compliance and follow up. No complications due to hypertension. Examination was no.
Okay. Right. Okay. Now, from a long case point of view, okay, we will just take out the young hypertension today and discuss it. Okay. But of course, this case, there is a sort of acute fever thing going on, but I won't discuss anything about that. I'll just focus on the young hypertension. Okay. Just focus on the young hypertension. Now, remember that young hypertension will never be the only problem in your long case if you get it for the exam, right? It is going to be one of the series of problems that the patient will have. Okay, එක විතරක් දෙන්න තියෙන chance එක අඩුයි, right? So the only problem young hypertension, that I don't think that's a possibility. So there will be some other problems mixed with the young hypertension. Okay, it's not a very common case, I have to admit, but because we've done quite a lot of long cases now and තව පොඩ්ඩයි තියෙන්නේ, but it's important to cover this topic because very well if one of you get it, aparadi, if you have not prepared for it. So just a basic overview is enough, right? Now, things that the examiner will be obviously interested in if you get a patient with a problem of young hypertension is about the etiology. Okay, about the etiology. Now, young hypertension, again, these age cutoffs are variable and various people define it in various ways. But in general, if the patient is less than 40, that, and this is the first diagnosis of hypertension, that qualifies for the diagnosis. Now, you have to be extremely careful, right at the start, right, to make sure that the patient really has hypertension. That is something very, very important, and that is something that you discuss at the exam. So if somebody asks you, what do you think the etiology is of this patient's hypertension, then you need to say, am I sure about the diagnosis, right? Am I sure about the diagnosis? Now, remember that hypertension has a very, very strict diagnostic criteria and has to fulfill that diagnostic criteria. That is extremely important. And in any guideline, they will give you the diagnostic criteria for hypertension. Okay. The latest one is this International Hypertension Society guideline, which you talked about briefly in your MCQ classes, right? So the patient should, number one, firstly, qualify for a diagnosis of hypertension. That is the first requirement. Now, that's the first requirement. So in this qualification, the technique is important, the cuff is important, lot of things are very important. Okay, the cuff, the technique, whether the patient is relaxed or not, all of these things come into that consideration. So the first thing you have to be is sure that this patient qualifies or fulfills the diagnosis of hypertension, and that you can extract from a history, and you can tell the examiner, I will look at the records also here, right? So that is something that you can say. Now, even then, you have to be very careful, because there is a group of patients with something called white coat hypertension. Okay, a group of patients with something called white coat, right, where their blood pressure is just elevated when they go to see a doctor, right? So as a general rule, in our unit and probably in several other units, we like to do an ambulatory blood pressure measurement as well in these young hypertensives, to make sure that we are not dealing with white coat hypertension. So ambulatory කියන්නේ, you give them a gadget, they do their usual day-to-day activities, and it records their blood pressure over the course of a day, right? And then you can see if the blood pressure is really high at home, or is this just an isolated white coat effect. So in a patient less than 40, like this 26-year-old, when they were diagnosed to be hypertensive, you need to be careful of two things then. The first thing is you have to say that I will make sure that the measurements, the cuff size, everything is proper and the diagnosis fits the criteria. And as a precautionary measure, I would like to exclude white coat hypertension by doing a 24-hour or ambulatory blood pressure monitor. ඔය දෙක පොඩ්ඩක් කියන්න as a background to your answer, right? As a background to your answer, you need to tell that. Okay, you need to tell that. Okay, right. So that is the first step. And I assume that this patient, and Shama told us that the patient has that 24-hour ambulatory blood pressure and all of that. So probably we are dealing with a proper diagnosis of hypertension in this patient. Okay. Now the next step is, what is the etiology? And that is a question that you will be asked at the exam. What do you think the etiology is? Now remember that hypertension, broadly, there are two types. Number one, you have essential hypertension, and then you have secondary hypertension. You have to be keep in mind that the younger the onset, the likelier there is that it is a secondary cause. The younger they are, it is likelier than that is a secondary cause. Okay, it's likelier that this is a secondary cause. What are the other indicators of a secondary cause for hypertension, right? So you have to say hypertension could be essential hypertension or secondary hypertension. Secondary hypertension, the patient is 26 years of age, so it is very, very important to think of a secondary cause. So younger the patient, probably it's a secondary cause. What are the other features that tell you that this is secondary hypertension? One, the other features are patients presenting with hypertensive emergencies, right? So if they have hypertensive emergencies, that again tends you to think, could this be a secondary cause for the high blood pressure, right? Could this be a secondary cause for the high blood? So patients presenting with hypertensive emergencies, right? Then patients with accelerated end organ damage, right? Again, we would think of secondary causes, right? So patients with extensive or accelerated end organ damage due to hypertension. Again, you begin to think, could this be a secondary cause? So hypertensive emergencies, accelerated end organ damage are all features of possible secondary hypertension. The third thing that you need to keep in mind is the element of drug resistance. So if a patient is drug resistant, they are more likely to be secondary hypertensive. It is likely that they have a secondary cause. Okay, Drug resistance, as you know, patient has to be on 3 antihypertensives at their maximum tolerable doses. One of them has to be a diuretic. So the presence of resistance of hypertension again indicates this could be a possible secondary cause. Right. So the answer to the question then, what do you think about the etiology of this patient's hypertension? This is the way you discuss. So first thing first, you need to make sure the patient has true hypertension. Proper diagnosis, everything made. White coat hypertension excluded. If that is fine, then you say, right, could this be a secondary cause or could this be essential hypertension? Even a young patient can still have essential hypertension. We have seen that. But could there be a secondary cause? So the fact that a patient has hypertensive emergencies, a patient has extensive accelerated end organ damage, and the patient has treatment resistance, these 3 points would indicate the possibility of a secondary cause. And also, the fourth thing is either clinical or biochemical evidence of a secondary cause. Clinical, biochemical, or other investigative evidence of a secondary cause, which I'll come to in a little while. That is another point that would tell you that this patient has secondary hypertension. For example, if they have full-blown Cushing syndrome or something like that, then you think this is a secondary cause, right? So obvious. So what are the features then? Hypertensive emergencies, blood pressure causing accelerated end organ damage, treatment resistance, and then clinical or investigation evidence of a secondary cause. So these are what you would consider as possibilities for secondary hypertension. Hari. Then, how would you investigate a patient for secondary hypertension? How would you investigate a patient for secondary hypertension? Now, before we go into that, okay, we just again revise the broad categories of causes of secondary hypertension. Okay, you know them already now. I don't need to revise a lot of this. You have cardiovascular causes of secondary hypertension. Of these, two you have to remember. One is coarctation of the aorta. Okay, one is coarctation of the aorta. Right. The clinical hallmark of coarctation of the aorta is the discrepancy in the upper extremity to lower extremity blood pressures and pulses. That is the clinical hallmark of coarctation of the aorta. So the discrepancy in the upper extremity to lower extremity pulses and blood pressure is the hallmark of coarctation of the aorta. Right. Another cardiovascular cause that can be mistaken for secondary hypertension is large vessel vasculitis. The example classically we give is Takayasu arteritis. Okay, common in Asians, right? And the typical clinical hallmark of Takayasu arteritis would be absent pulses. Okay, and vascular bruise in the sort of supraclavicular subclavian regions, right? Carotid, subclavian, supraclavicular. So large vessel vascular, the classical example is Takayasu arteritis. So absence of pulses plus presence of vascular bruise in these vessels, mainly in the sort of subclavian, supraclavicular region. So that is something that you would consider as well, Takayasu. So those are two cardiovascular causes of secondary hypertension. Then comes renal, and you know that pre-existing renal disease can cause secondary hypertension, pre-existing renal disease, right? Anything from congenital diseases like polycystic kidney disease to end-stage renal failure, these can cause secondary hypertension or renal hypertension. Another frequently sort of missed diagnosis in renal disease is renal artery stenosis, right? Renal artery stenosis. The typical hallmark of renal artery stenosis is they come to you with flash pulmonary edema, very sudden episodes of pulmonary edema, right? And there are renal artery bruise when you auscultate, renal artery bruise when you auscultate, right? So renal, any form of renal disease, starting from congenital disease like polycystic to end-stage renal failure, renal vascular disease like renal artery stenosis. All of these can present with secondary hypertension. And you know, clinical hallmarks of renal artery stenosis would be renal bruit plus flash pulmonary edema. Right. Now, a range of endocrine diseases can also cause secondary hypertension, right? mainly disorders of the adrenal gland like pheochromocytoma or disorders affecting aldosterone secretion, which we'll talk about in a little bit more detail next. Okay, so disorders mainly focusing on the adrenal medulla like pheochromocytoma, right, and disorders of the adrenal aldosterone mechanisms, aldosterone pathways, okay, can cause hypertension. Now, remember that uh, pheochromocytoma, the typical clinical hallmark is very paroxysmal headache, um, fear, tachycardia, palpitations, sweating, that sort of thing, right? Episodic, episodic. This is because these adrenal hormones are released in a pulsatile manner. So, episodic symptomatology. So, that's a clinical hallmark of pheochromocytoma. Other adrenal gland diseases can present without, may not have any symptoms or anything at all. Okay, but if they have sort of something like Cushing's, they will have the phenotype of Cushing's, right? Most of the adrenal cortical disorders affecting aldosterone cause hypokalemia. So they might have, for example, proximal muscle weakness due to hypokalemia, right? So that you might see. So cardiovascular, you have coarctation of the aorta and you have Takayasu arteritis. Then renal, you have any sort of renal disease, renal artery stenosis, and I've told you the clinical hallmarks of renal artery stenosis. Then endocrine diseases, mainly disorders of the adrenal gland, pheochromocytoma in the adrenal medulla, or anything affecting the aldosterone pathways, right? Adrenal cortical disease affecting the aldosterone pathways. Now, obviously, other endocrine diseases like thyrotoxicosis and rarely even things like acromegaly can cause secondary hypertension. But it's easy to diagnose them because they have other features, right? Other obvious features, right? And most of them can be clinically diagnosed. Okay, so cardiovascular, renal, then you have endocrine. Then respiratory. Funny enough, respiratory disease is actually one of the leading causes of hypertension now, and that is because of obstructive sleep apnea slash obesity hypoventilation syndrome. Sometimes they coexist. And that is one of the leading causes of hypertension now, in especially in obese people. Okay. And when you correct it, the blood pressure improves. So that is another thing that people are now interested in, right? Obstructive sleep apnea related hypertension. Okay, right, fine. Okay, so respiratory. Then, of course, you have a large group of miscellaneous causes which include medication, various drugs, and the commonest things that we have come across in clinical practice are things like OCP use, oral contraceptive use, right? Oral contraceptive use, and other medications. The other miscellaneous category also includes various genetic disorders of hypertension, but those are exceedingly rare. Okay, various these are Mendelian inherited genetic disorders of hypertension, which are very rare. So what we're trying to do is we're trying to answer the question: what are the investigations that you need to do? And I'm starting off by saying that we need to list out the possible causes and then work it out from there. So we have talked about cardiovascular cause of secondary hypertension, renal causes, endocrine causes, obstructive sleep apnea, respiratory related cause, and then other causes like OCP use and other medication related hypertension. Right. So what do you do? What do you do? Now remember, you have to do obviously a clinical examination and history. Some of these will be diagnosed based on your history and examination. Fine. But then you need to do certain specific things also to diagnose. Now let's go from the top. If you talk about cardiovascular disease, we talked about coarctation. The main investigation you would do is echo. In that case, of course, to confirm it, you need to do a CT aortogram to confirm it, but echo in the first instance. Takayasu arteritis is rare, but in young females with clinical evidence, ESR will be elevated. Okay, ESR will be elevated. And again, a vascular angiogram is what you do to diagnose it. vascular angiogram is what you do to diagnose it. So these are okay. Then for renal disease, you need to obviously do a basic panel of kidney tests, right? Basic in any patient with secondary hypertension, you have to do this basic panel with proteinuria, creatinine, electrolytes, and then an ultrasound scan of the kidneys. Okay, you have to do those basic tests in all people. Okay, creatinine, electrolytes, ultrasound scan of the kidneys you have to do in all of your patients. Right. Okay, and that will give you some information as to if there is a renal cause. Now a bit of caution here, මේක අර කුකුලද බිත්තරේද phenomenon වගේ සමහර වෙලාවට වෙන්න පුළුවන්, because you don't know sometimes whether it's a renal disease causing the hypertension or the hypertension causing the renal disease, right? So that is a bit of a difficulty sometimes, right? For renal artery stenosis, you have to first do an ultrasound scan abdomen, which we already mentioned, and you start to suspect it when it's unilateral. You can start to suspect it from the ultrasound scan, where there will be a size discrepancy between the kidneys of about more than 1.5 centimeters. So the kidney sizes will vary more than 1.5 centimeters. But again, the definitive diagnosis of it, you can do a renal Doppler, but again, that is not the definitive diagnosis. That is a subsidiary or some additional diagnosis, but the main diagnosis is made again by angiogram. Okay, renal angiogram. This could be CT or MRI or whatever, renal angiogram. But the basic step is you start off by doing the ultrasound kidneys and then going from there. Another word about renal artery stenosis is that most of the time this is diagnosed when the patient is put on ACE inhibitors. A significant rise of creatinine, more than 20% on ACE inhibitors, is something that makes you think of renal artery stenosis. Okay, more than 20% rise when starting ACE inhibitors in the creatinine. That is something that makes you think of a renal artery stenosis. So there are some clues there. Ultrasound might show a kidney size discrepancy. Angiogram is the best mode of diagnosis. Fine. Now, endocrine tests, okay, starting from the really basic endocrine test, because we were saying that pheochromocytoma is a possible cause, you need to do the metanephrines. Urine is best, plasma is best, but that's a bit expensive. So urinary metanephrines are what you can do, urinary metanephrines. Urinary VMA is less sensitive and specific. Better if you can do the urinary metanephrines, or plasma metanephrines would be better. Okay. Now, for the aldosterone related things, a basic screening test would be the serum potassium level. Okay, aldosterone related things. But remember that, because why is this? Because aldosterone increases the potassium secretion. It also causes a metabolic alkalosis. So basically, if your patient has a metabolic alkalosis with hypokalemia, that actually points you towards the aldosterone related problem, or that pathway problem in the adrenal gland. So what are the investigations? Hypokalemia with metabolic alkalosis will point you towards that. Okay, will point you towards that. Things like thyrotoxicosis easily diagnosed with thyroid functions, right? And I'm not even going to talk about acromegaly because that's not very important at this stage, right? For respiratory obstructive sleep apnea, obesity, hypoventilation related hypertension, you have to do a sleep study. Okay, you have to do a sleep, but a sleep study karanna. If the patient is obese or has features of it, then you do it, right? A sleep study. And you'll be amazed at weight loss and treatment, like for example, giving something there, you have to look for it. You have to look for it. If the patient has the clinical picture, then you do their sleep studies. Then the other causes like medication and things, it will be from a history. Medication could include illicit medication also, where you might do their urine tox screens and things like that as well, right? There are many drugs, illicit drugs, that can cause hypertension. Cocaine is a well-known culprit. Then amphetamines are a well-known culprit, which can cause hypertension. So especially in this day and age where people are addicted to these substances, those are things that you also might need to consider. Okay, right, right. And also I talked about very rare genetic ones. So if it's a very strong familial, say for example, autosomal dominant or sort of family history, then you might do genetic studies. But that is not, I have never, yeah, maybe seen one in my life. Very, very, very rare. Okay, very rare. Okay. So basically then Lama, if to investigate the cause, if you don't have any clues from the history, the basic panel you need to do are, right, echocardiogram, that's for the cardiovascular stuff. Okay. Then for the renal stuff, you need to do the serum protein, sorry, urine protein, the albumin creatinine ratios, creatinine, electrolytes, and renal ultrasound scans. Renal arteriosclerosis, again, discrepancy in the sizes of the kidneys would be a clue, but then you need to confirm that Doppler, then ultimately with angiogram, right? Then endocrine things, right? Urinary metanephrine, plasma metanephrines are important to do. And then the potassium blood gas would point you towards a aldosterone related problem like metabolic alkalosis hypokalemia combination, that might point you towards a aldosterone related disease problem, disease state. Okay. Then finally, respiratory you need to consider, not in all people, you need to consider doing things like sleep studies. Okay. Thyroid function aromatherapy for endocrine, I forgot to mention. And then screening for drugs and other illicit substances might also be indicated based on your history. Okay. So panel letter, that is what you're generally talking about to make the diagnosis. Right. Right. Okay. Now, a word of another very, very important thing here is that sometimes you can't wait for these investigations to come back to treat the patient. And I would recommend, if you're doing that, to use a medication that doesn't interfere with the renin angiotensin aldosterone axis, right? So that is just a little bit of a practical point, because as you can see, a lot of things are related to this aldosterone pathway. So medications that interfere with the renin aldosterone axis, if you give them, that will be a problem in making a diagnosis. So usually in these young hypertensives for sort of investigations, you put them either on a calcium channel blocker or an alpha blocker. That is the usual practice. You don't put them on ACE inhibitors or spironolactone or things that can directly interfere with the renin angiotensin aldosterone system. That is an important point for your long cases as well. As you can see in this patient, initially prazosin was started probably because of that, right? By the patient who had side effects to it. Right. Okay. Shahama, could you tell us the patient? You said this patient had hypokalemia. Is that right? Shahama?
Yes, sir.
Yeah, the patient had hypokalemia, right?
Yes, sir.
Do we know what level of potassium the patient had exactly? Did you manage to go through any fold investigation to find out how low the potassium was?
Initially, that was 3.2, sir.
Okay.
Then the repeated potassium level was normal, 4 millimoles.
Okay, but initially,
and patient was told that due to the vomiting, she had hypokalemia.
Okay. Right. So, do we know what the blood gas was?
No, sir, I couldn't find a blood gas investigation.
Okay. So yes, so what is interesting is this patient had hypokalemia, and the potassium 4 was before starting on ACE inhibitors. Is that right?
Yes, sir.
Okay. Right. It's very difficult to say whether hypokalemia is due to vomiting or not without knowing blood gases and other related investigations. But let's just for discussion purpose, and this is a very common line of discussion at the exam, assume that this young patient had low potassium, okay, had low potassium, right? So hypertension with hypokalemia, right, which is a very important topic for you guys to know at the long case. So what are the causes of hypertension with hypokalemia? And this is often accompanied by a metabolic alkalosis, more often accompanied by a metabolic alkalosis. Right, what are the causes? Now, the large group of causes of this are due to aldosterone excess, okay, aldosterone excess, right? Predominantly, hypertension with hypokalemia most of the time is due to aldosterone excess, okay. Now, aldosterone excess එන්න පුළුවන් එක එක විදි තියෙනවා, right? විවිධාකාර ක්‍රම තියෙනවා. ඒවා ඔයගොල්ලෝ දැනගන්න ඕනේ. Those are postgraduate things. But if you know that Con syndrome or primary hyperaldosteronism is one of the common causes, that is enough for me, right? So how is it? You say hypertension, hypokalemia, what are the causes කියලා exam එකේ ඇහුවොත් උත්තර දෙන්න විදිය තමයි මේ කියන්නේ. You say most of the time hypertension due to hypokalemia is due to aldosterone excess, due to primary hyperaldosteronism. That is your first important answer, right? First statement, okay. Primary hyperaldosteronism due to aldosterone excess, primary hyperaldosteronism, right? Primary hyperaldosteronism. Number two, it can also be due to, right? It can also be due to other tumors secreting cortisol, okay, cortisol, because as you know, cortisol has an aldosterone-like action, right? And that can cause aldosterone-like effect, okay? So most of the time it is due to aldosterone secretion, okay? Aldosterone secretion, right? Due to primary hyperaldosteronism. So that or cortisol, which has an aldosterone-like effect and sort of stimulates the receptor, right? Thirdly, these are rare, but there are aldosterone-like substances, okay? There are aldosterone-like substances which are increased in various conditions, okay? Yeah, one of them is deoxycorticosterone, okay? Deoxycorticosterone, which are elevated in various enzyme problems within the adrenal cortex. Okay? Deoxycorticosterone wage eva. So as an undergraduate, you need not know details about this. You have to say that hypertension, hypokalemia, first thing that comes to mind is primary hyperaldosteronism. But remember that I also know that tumors secreting cortisol can also have an adrenal aldosterone-like effect that can cause this problem. And then I also know that there are various other aldosterone-like substances that cause the same effect that aldosterone causes. Okay, the same effect that aldosterone causes. There are various substances that mimic the action of aldosterone. One of those is deoxycorticosteroid. Okay, so this is predominantly the cause of hypertension with hypokalemia, right? At an undergraduate level, one more thing that you need to remember: hypertension and hypokalemia can also be due to renal artery stenosis, right? Hypertension, hypokalemia can also be due to renal artery stenosis, and that is basically because of the low renal flow that automatically triggers the renin-angiotensin aldosterone axis, right? That is why there is hypertension and again that is aldosterone. So renal artery stenosis, renal blood flow is low, that triggers the secretion of renin and aldosterone. Okay, that causes the blood pressure to go up, and the potassium is basically how you would explain hypertension. So at the exam, if they give you a report saying the potassium is 3.2, what do you think? You would think that in a young patient hypertension, the first thing that I know is that hypertension, hypokalemia, something wrong with the aldosterone pathway. Because my basic physiology, you know that aldosterone causes excessive secretion of potassium and that causes hypokalemia. So primary hyperaldosteronism or cortisol mimicking the action of aldosterone, or other aldosterone-like substances like deoxycorticosterone due to various enzyme deficiencies within the adrenal cortex can cause this picture, right? Can cause this picture. I also know that hypertension, hypokalemia could be due to renal artery stenosis because of the low renal perfusion. It drives the secretion of renin and aldosterone. එච්චරයි. ඔයිට වැඩිය ටිකක් සංකීර්ණයි because there are various disorders. දැන් මම ඉස්සලා ගියාට මම කියන aldosterone, primary hyperaldosteronism, cortisol mimicking the action of aldosterone, other aldosterone like substances කියලා කිව්වනේ. ඒ substances කියන ගොඩට එක එක ಜಾති ගොඩක් එනවා. Right? There are various disorders that come under that category. But as an undergraduate, you don't need to know about those, right? If you know primary hyperaldosteronism, that is more than enough for your level. And maybe renal artery stenosis will එනවා කියලා දැනගත්ත මැති, but remember this is a bit more complicated postgraduate topic. ඒවා ඔයගොල්ලන්ට දැනගන්න අවශ්‍ය නැහැ. Right. Then the examiner will ask you, find primary hyperaldosteronism, how would you diagnose, right? As an undergraduate, you need to know the answer to that question. As an undergraduate, you need to know the answer to that question. How do you diagnose primary hyperaldosteronism? The first thing to do is a aldosterone-renin ratio, right? First thing to do is aldosterone-renin ratio. What will happen? Aldosterone will be high, renin will be low, right? Because of the feedback. So primary hyperaldosteronism is a tumor secreting aldosterone. When that goes up, that suppresses the renin, right? That suppresses the renin, and renin will be low. Okay, renin will be low. Okay, renin will be low. So aldosterone goes up, renin will be pushed down. That is the first thing that you do. I want you to think what will happen to the aldosterone-renin ratio in renal artery stenosis. Just think about it and try to work it out. What happens? And how do you make that difference? So primary hyperaldosteronism, aldosterone will be high, negative feedback on renin, and that goes down. So the ratio you can judge. And there are various cutoffs. The first step to do is a aldosterone-renin ratio. Very, very important. Right. Now, there are very specific protocols when you give advice to patients preparing for an aldosterone-renin ratio. And there are leaflets around, which I want to just put on your group. There should be things around. Even your previous groups had access to those leaflets. There are very, very important things, right? For example, the patient should be ambulatory before the test. The patient should not, and underline the word not, be on spironolactone because it affects the ratio, right? Before the test, right? And preferably they should be off ACE inhibitors and other angiotensin related, aldosterone related medication, right? So there are very strict guidelines as to what you need to tell the patient. That is something that they might ask you when you say aldosterone. What is the advice you would give the patient? So those are important questions, right? Because the aldosterone ratio changes with posture, they need to be ambulatory just before the test. There are certain medications that you need to be stopped, like spironolactone needs to be stopped. Also try to stop ACE inhibitors, angiotensin receptor. It's not essential, but you have better if you can stop them. And there are other precautions which they might, those are the two main things, right, that you need to tell the examiner that. Okay. Now, once you have demonstrated that aldosterone is high, the next thing is to find out where it is coming from, And for that, you need to scan the patient. So a CT scan might show an adrenal tumor. Okay, a CT scan might show an adrenal tumor. If it doesn't show an adrenal tumor, there are various other endocrine ways of getting to the answer, but those are again postgraduate stuff. Okay, if you know basically how to diagnose primary hyperaldosteronism, you can do a definite, first do a serum aldosterone-renin ratio, then do a scan. That is more than enough, and you should know the rough sort of guidance for a patient who is going to undergo aldosterone-renin ratio. Okay, right. So that is basically how you would investigate a patient with hypertension and hypocalcemia. So you should know at least three causes of hypertension, hypokalemia. Mainly things related to the aldosterone pathway. Okay, and there are obviously primary hyperaldosteronism and many other various things, other substances that can mimic the action of aldosterone. Okay, cortisol being one. There are various other things like deoxycorticosteroid, deoxycortisol, homogaga, and there are various genetic enzyme defects that cause accumulation of these substances. If you know that, that's enough for me. Okay? And you should also know it, renal artery stenosis, also the aldosterone levels are high and you get hypokalemia with metabolic alkalosis. And then the next step is how do you investigate the aldosterone renin ratio and the scan to confirm the origin of the hormone. Remember, write that down. You never do this in reverse. You never do the scan first and then do the hormone. In any endocrine investigation, it's first the hormone, then the scan, right? Because there are things called incidentalomas, various tumors all over our body. They're just sitting there, not causing any trouble. So if you don't do the hormone first and then the scan, you are in the danger of picking up various unnecessary masses all over the body, which are just sitting there without a problem. So always hormone, then CT, right? That is very, very important. Hurry. So that is how you investigate a patient with secondary hypertension for to arrive at a diagnosis. And Shama, I assume that all these or most of these investigations would have been done in your patient, and like metanephrine, renal functions, aldosterone, renin, all of that would have been done. Shama. Okay, that's okay. We seem to have lost. Right. Okay. So that is basically how you would investigate a patient for a cause. Right. That is basically what you need to know about young hypertension. Now, apart from this, right, are there any other investigations that you need to do in a patient with young hypertension? The answer is yes. You need to look for end organ damage. You need to look for end organ damage, right? If the examiner asks, what are the other tests you would do? You look for end organ damage, right? Now, end organ damage, primarily what you can look for is cardiac and kidney, right? Cardiac and kidney and retina, okay? Heart, kidney, and retina. These are three main places where you can screen, right? So, echo, ECG, renal functions we have already done for the cause, and a dilated fundoscopy would be another thing to do. So what are the other investigations? The question is, what are the other investigations you would do? Investigations to look for target organ damage, right? Right? Echoes, ECGs, renal function tests, fundoscopy. Finally, there are some other investigations also that need to be done. Apart from target organ damage, you need to screen the patient very, very carefully for other metabolic risk factors, right? So apart from the target organ related investigations, you need to screen the patient for other metabolic risk factors, right? Other metabolic risk factors. This would be lipid profile, sugar, වගේ දේවල්. Okay? Lipid profile, blood sugar, වගේ දේවල්. Fine. Okay. Now, about medication, I am not going to go through because we have discussed this in your MCQs classes. We talked about guidelines, you wrote an SCQ also, if I can remember, about the medication. But the specific thing I need to tell you about young hypertension, I've already told you, and I will remind you that until your investigation process is complete, it is best to keep the patient off medications that interfere with the renin angiotensin aldosterone system, and you know the reason now. Okay, and especially things like spironolactone, definitely no spironolactone, right? And preferably no ACE inhibitors, angiotensin receptor blockers, right? So that is what you need to remember when you're managing a patient with young hypertension. If you find a cause, treat the cause, the blood pressure improves. But sometimes you can't find a cause, however much you investigate. Okay? And then you'll have to just manage the blood pressure. But at least until you reach a diagnosis or exclude certain things, don't put them on medication that interferes with the angiotensin aldosterone axis, right? Be careful when you're doing that. Okay, right? And that is twofold. The reasons are twofold. One is because it interferes with the test, and also if the patient has renal artery stenosis, you're going to knock off their kidneys. So for those two reasons, you'll be very carefully interfering with this aldosterone renin axis, right? So you're not going to play around with that too much. Okay. So those are the questions, potential questions and answers for a long case where you have a patient with young hypertension. So let's just recap about the case that we discussed. Please put questions on the group and I will answer them at the end. So we have a 26-year-old female who has hypertension. Okay, that is what we discussed. Headache, but those are non-specific complaints. There was maybe one or two readings of hypokalemia, but then we didn't find anything. She has been investigated thoroughly, but no cause found. So I first of all gave you a definition of young hypertension and a question on what is the etiology. And I told you that before you answer that question, you have to make sure two things are there. One is the patient has been diagnosed with the proper criteria, proper cuff, proper method, and you have excluded white coat hypertension by doing an ambulatory blood pressure measurement. Right. Then what is the etiology? Etiology in young hypertension could be essential, could be secondary. The likelihood of hypertension due to a secondary cause is increased the younger the patient is. If the patient presents with hypertensive emergency, if the patient presents with accelerated end organ damage, if the patient presents with treatment resistant hypertension, the probability of this being a secondary cause is elevated or increased. Also, if the patient has clinical or basic investigation evidence of a secondary cause, like hypokalemia, for example, you would also consider strongly that this could be a secondary cause. That is your discussion there. Right. Then we went on to the etiology. What are the investigations you would do? But keeping in mind the clinical history and examination can be useful for certain things. And we went through the cardiovascular, respiratory, renal, endocrine, and other drug and toxin related causes of secondary hypertension. Right. And the hallmarks of clinical hallmarks of some of them. All of them can't be diagnosed clinically, some can. Right. Then investigations, I told you, cardiovascular, what are the investigations you do? Endocrine, what are the investigations you do? Respiratory, what are the investigations you do? Renal, what are the investigations you do? Then finally, we talked a little bit about hypokalemia and hypertension, where this patient was recorded to have hypokalemia at some point. Then I told that aldosterone-related problems are the commonest cause of hypokalemia and hypertension, and primary hyperaldosteronism leading that category. But also, other aldosterone-like substances or cortisol, for example, mimicking aldosterone action can cause the similar picture, right? Renal artery stenosis can also cause hypertension and hypokalemia. Okay. Then we went on to say, how would you investigate a patient for primary hyperaldosteronism using the aldosterone renin ratio? Then I told you certain things that you need to be careful about when you're doing the test, and you need to read a little bit more about that, right? Fine. Then what other investigations would you do? Screen for target organ damage, screen for other metabolic risk factors. Finally, about the treatment, you don't strictly follow this first line treatment principle when you treat a young hypertensive. You have to make sure that you try to keep them off the sort of drugs interfering with the aldosterone renin ratio before you exclude certain things, right? So calcium channel blockers, alpha blockers are reasonable drugs to use. That is it. Okay. Any questions? You can raise your hands and ask, or you can post them on the chat. No questions. I hope you people are studying now, right? So again, as I told you, please try to block out all other distractions and now focus on the exam in March, right? Don't focus on this whatever professorial in January or whatever for the moment. Nobody knows anything about that at the moment. You focus on the March exam. That is the most important thing. Don't worry about something and just stress yourselves out. Please focus, and you need to do very, very well at the exam. That is your main target. Okay, because it affects the sort of not the rest of your life, but at least the first 2 years of your clinical life it will affect, right? Then of course when you do postgraduate, the whole merit list thing goes out of the window. But for the first few years, it is going to affect your life. So make sure that you close out all other distractions and study. Right. Tirini?
Yes, sir.
Tirini, what's the plan now? We have done almost everything except rheumatoid arthritis and anemia.
Yes, sir. We found 2 histories, sir. We can do those in the next 2 days.
Okay, what are the histories? So you got a rheumatoid patient.
Yes, sir. And then anemia.
Okay, so let's finish those. So that will be
Okay,
by
sir.
Wednesday, we should be done with the long cases, and then we finish the short cases and then move on to emergencies. Okay. Tirini, just ask the group and let me know whether they would like to do the emergencies now, emergency OSCE now, or would they prefer to be done once you know about your final assessment for the professor appointment. තාම ඒක ගැන මුකුත් කිව්වේ නෑ නේද? වයිවා මුකුත් ගැන මුකුත් කිව්වද?
Nah, sir. Good.
නෑනේ. ඕක දැන් ජනවාරි ලෝක තියනවද නැද්ද කියන එක අනුව ගොඩක් බලපානවනේ. So just ask the group what they would like to do. I am okay with both. So just let me know. Okay. Whether they want
Okay,
to
sir.
stop at the short case or just continue and finish it off, or sort of when the dates are known for ski and viva, whether they want to do it closer to that. Whatever is okay with me. Sorry?
Okay, sir.
Okay, so 2 more days, long case is done. Then both, 3 days more, short case also done. Okay, and that will be okay.
Okay, sir.
Sorry, okay. See you tomorrow then.
So thank you very much.
Yes, sir.
Thank you.
Yes,
Yes, sir.
Thank you, sir.
Thank you, sir.